Okay, so now we're going to talk about some of the T cell targets. And some of these T cell targets alter or inhibit T cell activation. There's a few that are specific for actual T cells, which we'll cover in this particular section. And there's a few that are specific for some of these supplementary or assisting type proteins or markers. And so they're not T cell obviously specific, but they reduce the T cell activation. And so an example would be a monoclonal antibody against IL-2 or IL-1. And so just understand that when we talk about T cell activation, this is a general kind of concept. The stimuli for this activation process is actually going to be the tumor. Okay, it's not going to be a microbe. But the process is the same. These tumors are antigenic. They've got unique peptides that are different from self versus non-self, of course. And so the tumor is, of course, self, but it has a group of proteins that are very specific for some of these embryologic markers. And so they become immunogenic or antigenic, if you, whichever term you like. And so blocking T cell activation will also reduce the effector function of the cytotoxic T cells, which traditionally are the ones that go after some of these tumors, but also the activity of the B cells, which would be the ones that would be promoting humoral immunity by producing antibodies specific to the tumor cell. Now, one would surmise that these antibodies should be specific to this tumor cell and destroy it. Sometimes they don't, which is why we go after them as a target. Okay, so from a T cell standpoint, we can kind of start, I would say, start globally and then end up more specifically. And so here's an example. This is anti-thymocyte globulin, or ATG, and this is really a mixture of a whole different group of cytotoxic antibodies directed against T cells. And so what it does is it basically annihilates the T cell population, and we can use it to basically induce immunosuppression. And so these are the patients that have, like, aplastic anemia, but also patients that are going to undergo transplant. So what we need to do is we need to basically annihilate the whole T cell compartment. Okay, and of course this comes with some toxicities, which are listed here. So this is kind of a more global kind of pan T cell suppression. This is more specific. This is looking at anti-CD25 specifically. There's two drugs, one basiliximab and the other daclizumab. And the only difference really is that, sorry, there's a little bit of there we go, now it's easy to see. The only difference really is between these two drugs is how much human and how much mouse they are. Okay, and the differences are listed there. And so what anti-CD25 does is that, yes, it's a marker of T cells specifically, but CD25 binds, remember, to the IL-2 receptor. Okay, and so now you're going to be blocking that very dramatic T cell activation step. Okay, these drugs are pretty well tolerated. They are, of course, monoclonal antibodies. You can tell by the suffix MAB, and they're given IV. Of course, these aren't swallowed. The stomach acid would degrade them. The half-life is about 20 days. Okay, and so you can see, a nice dosing interval over a long period of time. We use basiliximab for acute organ transplant rejection prophylaxis, and we've used teclistamab. We've talked about this maybe once before in relapsing forms of MS, and so you can see this drug used for that indication as well. CD52 alemtuzumab causes a really profound depletion of T cells by specifically targeting the CD52 receptor. The effect lasts up to a year. Currently, we're using this drug for B-cell chronic lymphocytic leukemia. And so, yeah, of course, this is a B-cell leukemia, but it's being driven by T cell activity, T cell activation. Because remember, if you go back to that diagram here, the B cell activity is going to depend on T cell activation, and so that's the rationale for that target. In terms of side effects, you can see a rather profound first dose dependent cytokine release syndrome, and so that is kind of accompanied with fevers and general malaise, probably some tachycardia as well. But basically, as these dying tumor cells lyse, they release a whole bunch of cytokines into the bloodstream, and that really has a profound effect on the patient. Adverse effects include neutropenia, induction of CMV, and some of these other listed ones here. Okay, so that's kind of a quick overview of the T cell markers, and we will commence with further drug classes.